Right. Welcome officially to getting to know your pelvic floor. Laura, can you say your whole name for us?
It's Laura Tenekjian.
Tenekjian. Pete and I were having a fun time trying to pronounce it last night.
Yeah,
Awesome.
all those consonants in there.
Right. Well, a little bit about Laura before she shares her wisdom with us tonight. She is a physical therapist and has been practicing in the South Coast area since 2016. She attended the University of Mary Washington, earning a Bachelor of Arts in Art History in 2008. And after dabbling in the art world for several years, she decided to pursue a career in healthcare. She graduated from the University of New England with a Doctor of Physical Therapy degree in 2014. And she's worked in several different settings, including hospital, long-term care, and outpatient clinics. She's experienced in the treatment of orthopedic, neurological, and vestibular dysfunctions, but decided to focus on her passion, treating clients with pelvic floor conditions. Thank you. Laura has taken continuing education courses from the Herman and Wallace Pelvic Rehab Institute in order to become a certified pelvic rehab practitioner. And now she specializes in treating patients with various, somebody entered the waiting room, so I got a little distracted there. Now she's helping treating patients with various pelvic floor conditions, including bowel, bladder, and sexual dysfunction, weakness, and pelvic pain. She is dedicated to treating pregnant and postpartum women with pelvic floor issues. Now she resides in Rhode Island with her husband and 2 children, and she spends time with her family, being outdoors and staying active. Thank you so much for being here, Laura. Take it away.
Oh, okay. So I just, before we get started, I know Danielle mentioned that she has had pelvic floor therapy with me. And I was just wondering if anyone else, if you're willing to share, if you've had pelvic floor therapy in the past. I'd love to know if anybody's had experience with that. Of course, you don't have to share if you're not comfortable with it, but if you want to put in the chat if you've had it, it'd just be nice to know if anybody else is familiar with pelvic floor rehab. And if not, I'm happy to introduce it to all of you because I think it's a really important service to provide to our pregnant patients and postpartum women. So many people aren't aware that we exist. And I always get that in the clinic that no one ever told them that we exist. And then they found out later. So I'm happy that you're all here so you can be aware that you can certainly have this service. All right, so we'll get started. As Carrie said, I have 2 children. These are my little nuggets. This is Ada on the left and Remy on the right. Ada is 4 months old, so I myself am 4 months postpartum. And Remy is 2. He's a wild, wild boy. And being a mother is one of the greatest joys of my life. And it's also the hardest thing I've ever done, as I'm sure many of you can also understand. And you probably feel the same way. Motherhood is a wild ride. Okay, so we're all here to support each other. All right, so welcome. We're so happy you're here. And the purpose of this presentation is to really get familiar with your pelvic floor, which is really the true core of our bodies. Also to familiarize yourselves with pelvic floor rehab as a service and what we can provide. And also, I'm giving a little bit of treatment options for different conditions. So if you can glean anything from that, that'd be great. And if you have any questions at the end, I'd be really happy to answer them. So I'll try to move through the presentation so that we have time for that at the end. So if you want to write down any questions that you have throughout the presentation, so that you don't forget, I'd be happy to answer those at the end. All right, so the objectives for today, we're going to talk a little bit about pelvic floor anatomy. We're going to talk about the functions of the pelvic floor. We're going to just review some changes that happen to our bodies during pregnancy. We're going to talk about some general exercise guidelines for pregnancy and postpartum. And then we're going to go over several different pelvic floor conditions, risk reduction and treatment. And then we're going to talk a little bit about back to intimacy and postpartum, and then we'll have room for questions at the end. And when I talk about the pelvic floor conditions, there are so many things that can occur. And, this is an hour presentation, so I'm kind of scratching the surface of several different common conditions that I see in the clinic with our pregnant and postpartum population. So it's not an exhaustive list, but it's some of the most common things. And I just want to say that none of this is meant to scare any women who might be pregnant, and like these are things that can happen to you, but I think being informed equals empowerment, and that's why I'm including all of these things. All right, so let's get into it. So what exactly makes up the pelvis? So you can see this is the bony pelvis. Okay, this is my model friend. So you have the two hip bones, and the two hip bones are made up of three parts. So you have the ilium, which is the large bone here. And then you have the ischium, the two sit bones on the bottom. So when you put your hand under your bum, you feel that bony prominence. Those are the ischial tuberosities, part of the ischium. And then you have the pubis in the front. And then in the back, you have the sacrum, which is that triangular bone, and then the coccyx. So all of these bony landmarks provide attachment sites for many of the pelvic floor muscles. And I'll get into the muscles on the next slide, but I just want you to appreciate how the pelvis is really like a basket, and the muscles make up the floor of the basket. So it's really that support system at the bottom, so literally the floor of your pelvis. And the pelvis is the center of the body. So you have to think about all your dynamic movements are going to come from this part of the body. Movements with the legs, the trunk, it all stems from this part of the pelvis. Okay, so we're going to get into the muscles. So this image that you see on the PowerPoint here, this is an inferior view. So you can imagine you're sitting at the gynecologist's office and your legs are up in the stirrup. So you're looking straight on at the pelvic floor muscles. So the pelvic floor muscles are made up of two different muscle layers. So you have the superficial muscles that surround the entrance of the vagina and the anus. So these are considered superficial, fast twitch muscle fibers. So you can think of these muscles, they provide a quick flick. They're short endurance. So think like if you had to go to the bathroom, you needed to hold it, you would flick your muscles really quickly, and that's mostly the superficial layer. So these muscles don't have a long endurance, they're fast twitch muscle fibers. The deeper fibers are the deeper muscle layer. So these are called slow twitch muscle fibers. These contractions are going to be stronger, they're longer endurance. So if you think about like when you have to bear down to have a bowel movement or a vaginal delivery, those are the muscles that are really going to be acting. They're slower to fatigue, so that muscle endurance is a little bit longer. So the combination of these two muscles and those movements it makes up a Kegel, which we're going to talk about a little bit later. But in order to do a Kegel properly, you have to be able to recruit both of those muscle layers, the superficial and the deep. You don't want to miss out on either two. So there's three states of the pelvic floor muscles. There's a pelvic floor contraction, so pulling up and in. Then there's the relaxed state or a neutral state, and then the bearing down. The bearing down, like in a vaginal delivery, is probably like when you have to be at your strongest. So the pelvic floor muscle needs to be strong to contract, and it needs to be strong to bear down. Okay, so when we talk about pelvic floor strengthening a little bit later, and we'll practice the Kegel to make sure that we're all recruiting the correct muscles. Okay, so I'm not going to be holding this the whole time because it's distracting, but I just wanted you to get an appreciation of where the muscles are and what they do. So we're going to talk about the different functions of the pelvic floor muscles next. Okay, so we have the 5 S's plus coordination of breath. So sphincteric, sexual, support, stability, sum pump, and coordination of breath. So you think of those as the 5 S's. So we're going to go over the sphincteric and sexual function first, because those are both contractions of the superficial muscle layer. So again, we're talking about the muscle around the vaginal opening, the muscle around the urethra, and around the clitoris, and around the anus. Okay, so these are superficial muscles. So these muscles wrap around the openings. So you can think of them as literal sphincter muscles. So if you contract those muscles, you're actually pulling the muscles around the urethra closed, and you're pulling the muscles out around the anus closed, so you'd prevent urine from leaking or gas from leaking. These muscles also have to relax and lengthen to allow us to urinate or pass gas. So again, they have both of those functions, contracting and relaxing. Sexual function, so during intercourse, the pelvic floor muscles help to achieve and sustain arousal because that muscle wraps around the clitoral hood. So you have to have sufficient strength of the muscles necessary for orgasm, but also excessive tension of these muscles or sensitivity of the pelvic floor can cause some pain syndromes like pain with intercourse or after intercourse, and we'll talk about that a little bit later too. Okay, and then we're going to move on to support, stability, and sump pump function. So these are contractions of the deeper muscle layer. So these deeper muscles that are within the pelvic bowl. And again, all the muscles attached to these bony segments of the pelvic floor. So support, so these muscles provide, they're at the floor of that basket. So they literally provide support for our internal organs. So inside of the bowl, not pictured here, they're not on my model, but inside the bowl, you have the bladder in the front, the rectum in the back, and then the uterus. So these muscles, they're all attached by ligamentous support, but without the pelvic floor muscles, not to be graphic, but those things would literally fall out without your pelvic floor. So you can imagine during pregnancy and afterwards, if that pelvic floor is weakened, things like prolapse can happen, which we'll also discuss a little bit later. So any increase in abdominal pressure puts pressure on the pelvic floor. So if we don't have that strong muscle system, anything that increases abdominal pressure can push down on the pelvic floor. So we need the muscle action to counteract that. Okay. So stability. So because of their attachments on the pelvis and the hips, these muscles are really important for all of our dynamic movement. So the pelvic floor and the core muscles are very closely related. So for any hip and abdominal movements, you have to have a strong pelvic floor so that those actions are safe to do, because you can get injured if you don't have that stability. Okay, sump pump. So just like the calf muscles provide pumping fluid and blood back to the heart. So in the same way, your pelvic floor muscles pump blood and lymphatic fluid back to the heart, and they act as a blood and lymph pump for the pelvis. So a loss of that function can actually create something called pelvic floor congestion, which is a pain syndrome, and it creates this kind of like full sort of dull feeling in the pelvic bowl, and that can be because your muscles are not pumping efficiently. Okay. And I don't think we mentioned this before, but this whole presentation would be available to you to print out if you want to do that later. I think it's available via Carrie's website, but she can talk about that later, just so that you have pictures and things like that to refer to. Okay. So we talked about the 5 S's. Now we're going to move on to coordination of breath and managing pressure. So I really like this image because it shows how the pelvic floor muscles work in conjunction with the diaphragm to breathe efficiently. So there's a relationship between the diaphragm and the pelvic floor. So as you inhale, the rib cage expands, the diaphragm drops, and the pelvic floor relaxes. As you exhale, the diaphragm lifts and the pelvic floor also lifts. So we're going to practice this a little bit. And when we get into actually doing some lower abdominal activation and pelvic floor activation, we're going to come back to this breath, because the exhalation is a really good time to contract those muscles. But we're going to practice the breathing right now. So if everybody just gets comfortable in their chair. So you're going to want to place your hands just underneath the rib cage, kind of under the chest, underneath the rib cage here. So you want to just let all the air out. Okay. And then when you take an inhale, you're going to inhale through the nose. And I want you to feel the ribs expand outward into your hands. So you're going to take a nice deep breath in and exhale out. Rib cage pulls in. So that's the movement of the rib cage and the diaphragm. Now your pelvic floor, when you inhale, the pelvic floor should drop or kind of expand out as you inhale. So as the diaphragm drops, pelvic floor should expand. So I want you to try to feel that on your next inhale. Okay, and try to relax your pelvic floor as you inhale. So take a nice deep breath in and exhale. As you exhale, the belly draws in. So like I said, that's a great time to actually contract your pelvic floor, and we'll practice that when we get to the Kegel. Everybody okay with that? Thumbs up, thumbs down. It takes some practice. Sometimes it's hard to feel what the pelvic floor is doing right away, but with practice, sometimes if you're lying down in a more comfortable position, you can really start to feel that pelvic floor expand as you breathe. Okay. So we're going to talk about a little bit, just some changes that happen during pregnancy. So the hormone relaxin, which is produced during pregnancy, creates increased ligamentous laxity. So if we think about, all the, there's a lot of cartilage and ligaments between all the bony structures of the pelvis. So that relaxin actually allows the pelvis to expand to make room for the fetus and fluid and the growing uterus. So we want that. But at the same time, that makes the pelvic floor muscles have to work a lot harder to support the joints and the organs. So if you have laxity in the ligaments, that means more more work for your muscles. So as your body weight increases, the pressure in the pelvis increases. So it's an increased workload for the pelvic floor. That's why it's important to maintain that strength during your pregnancy. The muscles and connective tissue begin to expand to make room for everything. And then as that expansion happens, there's actually decreased room for your diaphragm to expand for those breaths. So that's why it's really important to practice that nice deep breathing throughout your pregnancy, because the rib cage doesn't have a lot of space because the baby is taking up so much room. So that can make those deep breaths really difficult. So it's good to practice that throughout the pregnancy. Okay, and then we're going to talk about just basic guidelines for exercise during pregnancy and postpartum, because as we get into talking about some of these different conditions that occur, I'm going to be talking about exercise, and I want this to already be known, just about the different parameters that we recommend. So exercise during pregnancy, the main objectives here are to maintain or improve your pelvic floor strength for labor and delivery. As we talked about, your pelvic floor, the strength is really important for that bearing down. If the muscles fatigue quickly, or the bearing down part of labor, which is so much of it, is going to be really difficult. Maintaining core strength for carrying your extra loads. You want to make sure that your belly is nice and strong to kind of off weight the pubis during pregnancy, and we'll talk a little bit about that later. And you also want to maintain your cardiac health and fitness for labor and delivery. So I always say, if you are exercising before you're pregnant, you can continue doing what you're doing as long as it feels good in your own body. It's not the time to start like training for a marathon or anything new, but definitely doing things, gentle strengthening, walking, running, if that's what you've been doing. But you always want to listen to your own body, speak to your healthcare provider if you have any concerns about exercise during pregnancy. And then exercise in the postpartum period. In general, we recommend waiting until that 6 weeks post-vaginal delivery. I know someone mentioned they started their pelvic floor exercises in week 1. I don't think that's a bad thing to do, but it's just that, in practice, we can't tell people to start that early because there could be some underlying conditions that we're unaware of. But in general, we like to wait till that 6 weeks post vaginal delivery. And post C-section, we like to wait 8 weeks just because of that incision needs to heal and everything needs to be healed and feeling good. With that said, I often recommend starting some of that some breathing exercises, some abdominal activation before that 8 weeks can really help to reduce any issues that can occur. And then you want to make sure that exercise is safe for you. I have a lot of clients who come in postpartum who have pelvic pain syndromes, and they were told to start Kegels right away after labor and delivery. And the Kegels actually created a worsening issue. So you really want to ask yourself, like, do I have pelvic pain? Does this exercise feel good for me? And if it doesn't, or if you have concerns, I highly recommend seeking out a pelvic floor therapist, talking to your midwife, your gynecologist, or your healthcare provider of choice, just to make sure that exercise is safe for you. So that's my little spiel there about exercise. And And the basic thing is to really strengthen from the inside out. You don't want to start with big dynamic movements or running before you really strengthen the abdominal muscles, because that can lead to injury. So again, I'm going to get into a little bit of the postpartum exercise program, but in order to do it really safely, if you're not familiar with exercise, you really want to talk to a healthcare provider or a trainer. Okay. So we're going to talk about pelvic floor and pain conditions during pregnancy and postpartum. So we're going to start with postural changes and back pain. We'll talk about incontinence or leakage of urine. We'll talk about a diastasis recti or a core weakness, pubic symphysis dysfunction, prolapse, and lastly, pelvic pain and pain with intercourse. All right, everybody hanging in? Good? Okay. All right. Take a sip of tea. All right, so we'll talk about postural changes in back pain. So I wonder, like, what does my back have to do with my pelvic floor? But it's all very related. So when we think about where the spine is in relation to the pelvic floor, so your spine connects to the sacrum to coccyx. Some of your pelvic floor muscles actually attach to the sacrum. So anything that happens along the spine can affect your pelvic floor and vice versa. So during pregnancy, we all know the uterus grows, okay? So the pelvis is going to naturally start to tilt forward during pregnancy, which creates excessive, what we call lumbar lordosis, or a curve of the low back. So that curve of the low back creates more pressure through the sacrum. So the sacrum meets that lower lumbar spine. So as that tilt happens, the curve becomes more excessive and create a lot of pressure through your sacroiliac joint. So again, anterior pelvic tilt creates more pressure through the sacrum. So we want to do everything we can to try and bring that pelvis back. During postpartum, we want to stare at our beautiful baby all the time, whether we're breastfeeding or bottle feeding. We're always going to be looking down, and our shoulders are forward and rounded. So we call it increased thoracic kyphosis, which basically means that I don't have my whole spine, but the upper spine starts to come forward, and that creates a lot of tension of the muscles between the shoulder blades. So that constant, holding the baby, looking down, picking up, that creates, and sometimes our chest gets bigger and heavier. So that creates a lot of pressure through the mid back. So I often have a lot of complaints about mid back pain. And then neck flexion is often increased. Again, you're looking down at the baby, you're looking one way or the other. So a lot of times the neck and shoulders can become really painful. So I'm going to give you a couple things to do for that on the next slide. All right. So first of all, check your posture. I think Carrie had a nice post on Instagram one time about just like, if you're standing in the kitchen or doing something, you want to really check your posture. Am I looking down, or my shoulders rounded? Just kind of, fixing your posture a little bit, bringing the shoulders back can really be helpful. Tilting the pelvis, pelvis back can be really helpful. So these are my top 4 kind of pregnant and postpartum stretches, things to do to alleviate back pain. So this first one up here, the half kneeling hip flexor stretch, can be done safely in pregnancy or postpartum. It's a really nice way of creating, again, that posterior pelvic tilt, really bringing the pelvis back out of that anteriorly tilted position. So when you get into that position, you want to have your knee supported on a pillow, just because that can be uncomfortable if you're right on the floor. And you really want to try to engage the abdominals so that your pelvis tilts forward. Okay, you want to take that curve out of your low back. And then reaching the hand overhead can really alleviate the side of the back and any sacroiliac pain that you can have through the hip. So that's a really nice stretch and hip opener to do. Another one that I really like that can be done in the kitchen, in the bedroom, on the couch while you're watching TV, you put your hands on any surface, lean down and really kind of shimmy the hips back. It can open up that low back really nicely. And you can also get a nice stretch to the shoulders. You could even, bring your arms to one side or the other to get a nice opening through the side body. And again, the stretch is really safe during pregnancy or postpartum. Foam roller, I usually recommend in the postpartum state, just because being on your back, getting in these positions, it might be okay for some people when they're pregnant, but not everyone would be comfortable getting into this position when you're, 7-8 months pregnant. Maybe earlier in the pregnancy would be okay. But a foam roller can be, if you have one, you could also use a rolled up towel or stacked pillows. But this is called thoracic extension on the foam roller. So it really gets you out of that rounded shoulder position. It kind of provides a nice massage through the mid back. So you want to lay on the foam roller so that it's perpendicular to your spine. And you're going to put your hands over your head and just lean back while you're supporting your neck. You don't want your neck to extend back too much. You really want to support that neck as you extend back on the foam roller. You might get some nice back cracks. It feels really juicy and good. Sorry, I didn't mean to use that word juicy. It's annoying, but it feels really good. Okay, and then another really important muscle to stretch is your pec. So the muscles through the chest get really tight with breastfeeding, with bottle feeding. Again, looking at that beautiful baby in your arms, everything gets really tight. So this person is lying on the foam roller so that it's parallel to your spine. I always recommend making sure that your head is supported on the foam roller or whatever surface you're lying on. If you're stacking pillows, if you're using a yoga bolster, just make sure that your neck is supported so your neck is not flexing back. And then just simply opening up the arms, just allowing that chest to open, holding it for a couple minutes or as long as you can tolerate it. It feels really nice. And I know all of these things take time, but self-care postpartum is one of the top priorities. You have to be well in order to take care of your baby. So taking a couple minutes a day just to, stretch, take a minute, get out of that posture that we're so often in can really help with mid back pain and low back pain. All right, the next thing is transverse abdominis activation. So I'm sorry if this image is small, but if you look, this muscle in pink here, can you see my pointer? Okay, good. So this is the transverse abdominis. So this muscle attaches to the pubic bone in the front. It comes all the way up. It wraps all the way around, attaching to the hip bones and the back and the spine. So this muscle is like your personal corset. If you think about, those corsets women used to have to wear, it really tightens around the belly, supports the low back. This is that, but in a natural way. So your transverse abdominal muscle during pregnancy, if you have a C-section delivery, this muscle is definitely going to be disturbed. So it stretches. It can still be strengthened during pregnancy and then also definitely in postpartum. But this muscle is so important to maintain back health and also to maintain, again, that good pelvic alignment so that you're not tilted forward. An anteriorly tilted pelvis basically means that transverse abdominis muscle is not being activated. When you activate that muscle, it pulls the pelvis into more neutral or posterior alignment. And that's what you want to alleviate that back pain. So we're going to practice this. So I want you to place your hands right inside of the hip bone. So you can feel that bony prominence in the front of the hip. If you feel just inside of the hip, that's where that muscle attaches. So we're going to practice engaging this muscle, and it doesn't take a lot of movement. It's a really small movement. The action of the muscle is drawing the belly up and in towards the spine. So we're going to come back to our breaths, this muscle activation. So you're going to take a nice inhalation. Everything opens up, diaphragm opens. As you exhale, I want you to practice exhaling and pulling the belly in. You should feel that muscle right in the hips activate and pull in. So that's the transverse abdominis. This is going to be a really important muscle as we talk about some other things that can occur during pregnancy and postpartum. It's a really important muscle to activate, again, for your back support, to make sure that your body can carry that load. Everybody good with that? I'm going to practice it again. We'll do it one more time. So first, just try to activate it without the breath, just kind of pulling the belly button in. Another metaphor I use is if somebody was going to come and punch you, you'd want to tighten the lower abdominals. So you want to pull the belly up and in towards the spine. It kind of changes your posture a little bit when you do it. Okay. So you're going to take a nice inhalation. Exhale. Pull the belly in towards the spine. Okay. So that's the transverse abdominis. We're going to talk about that a lot in the coming slides to activate that muscle. Other things that you can do during pregnancy, if you are having a lot of back pain and it's gotten to the point where you're very pregnant, there's not much is helping. I recommend the Stork Support Maternity Belt is really nice because it provides a lift to the lower belly and then it cinches around the waist. So it's a really nice way of supporting the belly if you have a lot of back pain during pregnancy. Some people find them a little bit cumbersome, but if you're standing all day, if you have work or if that requires you standing, or if you're a person who has to be on their feet all day, that Stork Support can be really helpful. I actually used it in the end of my pregnancy and I wasn't able to function without it. So that's anecdotal, but we do recommend that a lot. Okay. All right, let's move on to a fun topic called incontinence. So incontinence is the inability to hold urine or leakage of urine. So even non-pregnant women, women of all ages, I see this issue in many women and men alike. But urinary incontinence is correlated with the number of vaginal births. There was a report back in the 90s that out of 290 women, 46% of them reported urinary incontinence during exercise, and urinary incontinence that was correlated with the number of vaginal births that they've had. And pregnancy is one of the top 6 reasons for urinary incontinence. Fun for us, right? Okay, so let's talk a little bit about the role of the pelvic floor muscles with general urination. So first of all, the urge to go to the bathroom starts in the brain. So there's a reflex loop. So you get the awareness that your brain tells you that you have to go to the bathroom. The bladder muscle reacts to your brain signal, and the bladder muscle called the detrusor. So this muscle right here is called the detrusor muscle. It's around the bladder. We do not have control over that muscle. It's an involuntary muscle. But when the brain tells the body that it's time to urinate, that detrusor muscle starts to contract and squeeze urine out. The pelvic floor muscles have to relax and let urine flow. So they have a reciprocal relationship. So detrusor muscle contracts, pelvic floor muscles relax and allow urine to pass. That's in a well-functioning bladder and pelvic floor system. If you get the urge to go and you are not anywhere near a toilet, then you want that muscle around the detrusor to stay relaxed. The way that happens is the pelvic floor muscle contracts, tells the detrusor to relax so urine doesn't flow. And then you make it to the bathroom, then your pelvic floor muscle relaxes and allows the detrusor to contract. So if you, oh, I'm sorry, I just saw a message in the, okay, never mind. I distracted myself by looking at the chat, but that was from a while ago. Okay, where was I? Okay, so that's in a normal functioning bladder and pelvic floor system. If you, so there's 4 different kinds of incontinence. So the first one here illustrated is overflow incontinence. So this is when the bladder becomes overfull and your body, the reflex system is not regulated. So your body is not getting that awareness of having to urinate, but the bladder is full. So the detrusor muscle starts to contract. And then the pelvic floor muscles are weak or not ready to react to that. And then urine flows out. Stress incontinence is what we're going to talk about mostly here with regard to pregnancy and postpartum. Stress incontinence is when any external pressure to the abdominal area occurs. So a cough, a sneeze, laughing, lifting something that increases the intra-abdominal pressure, creating a contraction of that detrusor muscle when we're not ready for it. The pelvic floor muscles are weak or, again, not reacting quickly enough, and we leak urine. This is the most common one that occurs with pregnancy and postpartum. Because of that weak pelvic floor muscle, the increased abdominal pressure, that often happens. Urge incontinence is also common during pregnancy, but it's because we have to go all the time because the baby is sitting on our bladder. But urge incontinence occurs when the bladder is not actually full, but our brain is telling the bladder that it's time to go. So there is a disruption of the reflex loop where we've either learned the behavior of having to go really often without actually having our bladder full, and then our pelvic floor muscles don't react. So when I see this in the clinic, it's often, if you're somebody who goes just in case really often, if you're somebody who just goes for the sake of going, just in case, I'm going in the car for 2 hours and I'm going to pee, your body learns the habit of having to go too often. So really you should be able to hold your urine for 2 to 3 hours. That's how long it takes the bladder to fill. But of course, that's not everybody. And so this can occur. But I often find that behavioral modifications, keeping a bladder diary can be really helpful for this. It's a little bit more kind of beyond this discussion. We're going to talk mostly about stress incontinence as far as treatment. But if you feel like you fall into any of these other categories, again, I urge you to either see a urologist to get to be maybe referred to a pelvic floor therapist, or talk to your healthcare provider if you do have those issues, because it's not normal. Everybody, I hear that a lot. Oh, I pee my pants sometimes, but it's normal. It's not normal, and there are things that you can do about it. And I don't mean that to be mean, but it's true. Okay. All right. So we're going to talk about treating stress incontinence. All right. So we're going to talk about Kegels. So I know this is kind of like the most common thing that people think I need to do my Kegels, but why is it named a Kegel? So we're going to talk about a little bit about the history of the Kegel. So there was a doctor by the name of Arnold Kegel who was active in the 1940s and 50s, and he discovered that women could improve several conditions by contracting their pelvic floor muscles. So he so generously lent his name. So now we have the Kegel, and of course it's named after a man. Come on, we could probably change the name, but anyway, so he just realized that a lot of women could be helped by contracting these muscles. So he took credit for the Kegel. But unfortunately, there's a lot of there was and there still is some confusion about where those muscles are, how to contract them correctly. So we've gone over where the muscles are. So I hope you have a better understanding of that. So we're going to talk about how to actually do a Kegel correctly. So we talked about the superficial muscles and the deeper muscles. So when you do a Kegel, you want to think about two different actions of the pelvic floor muscles. You want to think about trying to close the vaginal opening, or think about trying to, squeeze the muscles around the urethra, like you're trying to stop urine from flowing. So those are those superficial muscles. Second, you want to think about lifting the anus up and in. So when you're sitting in your chair, kind of pull the sit bones apart a little bit. If just a disclaimer, if you're having any pelvic pain or anything like that, you might not want to practice this, just because that can lead to increase in pelvic floor tension. But if you're feeling okay and you want to practice this, I would encourage you to do that. So when you do your Kegel, you want to feel two different motions. So you're going to want to pull the vaginal muscles in to close the vaginal opening, and then lift the anus up and in. And then you want to drop it down. So the contraction and the relaxation are both very important. If you can pull up and in, but you don't feel like the muscles are relaxing, then you might fall into that increased pelvic floor tension category. And we wouldn't want to do a lot of Kegels. You'd want to be evaluated by a therapist before you start a program, because you really want to be able to relax those muscles, because building up tension can lead to other issues. Okay, so we're going to practice with our breath now. So like I said, doing the Kegel it's really good to do that on your exhalation. Okay, so inhale, that creates a relaxation of the pelvic floor, so you know you're in a neutral position. So go ahead and inhale. And as you exhale, blow the air out, squeeze the vaginal muscle closed, lift the anus up and in, and then let it go. Okay. Does everybody feel that contraction? And you may or may not feel the relaxation, but again, if you were in the clinic, if I was evaluating you, I'd be able to feel whether or not you're relaxing. A lot of people cannot feel if they're relaxing or not. So if you're unsure, it might be good to get evaluated, but you just want to make sure that you're able to feel that relaxation. So if you have stress incontinence during pregnancy, I always tell my pregnant clients, it's difficult to completely get rid of an issue because you're growing, the baby is sitting on top of your bladder. It's harder to completely eradicate an issue. I always recommend trying things during your pregnancy and then coming back postpartum to really start your exercise program. So something that you can do during pregnancy is called the knack technique. I don't know why it's called the knack. I don't have a history of it, but it's called the knack. So basically, if you feel a cough or a sneeze or you're lifting something, you want to try and engage the pelvic floor before you cough, before you sneeze, before you lift. That can decrease that that abdominal pressure that can cause the bladder wall to contract when you're not ready. So, you can practice right now. If you do that contraction and then cough, that can decrease the pressure on the pelvic floor. So that's just like a little trick you can try during pregnancy or postpartum. If you are postpartum and having stress incontinence, research has shown that if you do 8 contractions for a 10-second hold, 3 sets a day, that can really show some improvement in your pelvic floor and reduce incontinence by at least 50%. So, and that would be a 6-week program. Some people have better outcomes. Some people don't get better for one reason or another, but in general, that's a really good sort of basic exercise program for your pelvic floor. So that 10-second hold, it sounds like a long time, and a lot of people want to hold their breath during that. So, but you really want to be exhaling or counting while you're holding that 10 seconds. I find the easiest thing to do is count, because then you're not holding your breath, and you make sure that you're holding it for the full 10 seconds. So if we want to try that, so you want to take a nice long inhale, exhale, contract, and then count out loud 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then let it go. It might be difficult for some of us to hold it for that 10 seconds, and that's okay. You want to kind of work your way up to the 10. So if after 5 seconds you feel it let go, that just means that, you need to practice more, and hopefully eventually you'll be able to hold it comfortably for that 10 seconds. Okay. Everybody good with that? So again, there's other kinds of incontinence. So this was really basically treating stress incontinence only. Okay. All right, so we'll talk about core weakness or diastasis recti next. So diastasis recti occurs when the 2 rectus muscles in the front here, these 2 muscles here, well, I guess I could just show you on the slide. Those muscles actually separate because the linea alba, which is this stretch of cartilage in the middle, stretches. So this is not a tearing of the muscle. This is just stretching of the cartilage that is, or the fascia, the muscle layer between those 2 rectus muscles. So you can see in this picture, it's stretched a little bit. So it creates this separation between the 2 muscles. Just reiterating, it's not a tear, it's a stretch. And so I want to just turn it over to Carrie real quick, because she has a really good self-assessment video. And she wants to talk about it.
Oh, sure. I wasn't ready to talk.
Sorry.
Sorry. All of this is amazing, though. It's super affirming, being able to work with women in a different way than you have been able to as well, Laura. And we're doing so many similar things, so it's very interesting. But yes, for everybody who's in the live recording tonight, I would love to send you this video for a self-assessment. It's very easy to do as well. It only takes like a few minutes getting down on the floor to check things out. And it just gives you more information to be able to know where to go from there and what exercises are going to lead up to that returning back of the abdominal muscles. So yes, I will send that along with the PDF for the slides. So
Awesome. Thank you.
you.
Okay. So there's some studies that suggest that 66% of women actually get a diastasis during pregnancy, but the majority of those cases resolve early in postpartum. So, if you did the self-assessment, you might not you might have had it during pregnancy, but not postpartum. So typically it resolves, but some women do experience persistent weakness that can limit your ability to perform like activities of daily living, like lifting, carrying things. It can also cause some abdominal pain if you have a severe separation. Risk factors include multiple pregnancies, having a large baby, a C-section delivery could also increase the risk of the diastasis. Okay. So to treat a diastasis during pregnancy, it's really more about decreasing the risk of it becoming an issue during postpartum. So ways to do that is to engage your pelvic floor muscles. And I'm going to refer to pelvic floor muscles as PFM. It's just a little bit easier. And transverse abdominis is TRA, just for ease. So top 3 exercises that I recommend during pregnancy for positioning comfort and just maintaining that core stability are these 3 listed here. So the first one, side lying, it's a nice comfortable position to be in during pregnancy. You can certainly do the same exercise on your back, maybe with a wedge behind you if you prefer that. But I like side lying because you can actually feel the belly lifting when you're contracting the TRA. So lying on your side with your knees together, you're going to lift the belly like we practiced before, hold, contract the pelvic floor muscle, and then let it go. You could even add a clamshell if you're feeling super frisky and like you want to do more. That'll engage your muscles a little bit more and kind of create a little bit more difficulty for the exercise. Again, this is pretty comfortable and safe to do throughout pregnancy. Cat camel with a PFM and a TRA contraction as you exhale. So as you exhale into the rounded back, so engaging everything, you can really engage the abdominals and the pelvic floor muscles in that rounded camel position. And then you're relaxing and opening up in the cat position. So that's a really nice way of engaging that TRA. The third one that you can kind of do throughout the day, when you're standing, washing dishes, standing, reading a book, whatever you're doing and standing, you can really tilt the pelvis in that posterior position and engage the lower abdominals and the pelvic floor muscles. So in this picture, she's standing against a wall for reference. So as you stand against a wall, if you put your hand behind your back, you can feel the arch in your back. When you engage your pelvic floor muscles and the lower abdominals, the back is going to flatten against the wall. So if you're not sure if you're doing it correctly, this is a nice way of ensuring that pelvic tilt is correct. So it's a nice way of engaging the muscles, taking some of the pressure off the low belly and making sure that your muscles are nice and strong. You can also use a maternity support or a belly band during pregnancy just to kind of support things. It's not necessarily going to stop the diastasis from happening, but it's just for support. Okay, during postpartum, this is a time to really start to use your breath to activate the transverse abdominal muscles. So these 3 exercises are a really good place to start postpartum, whether you're doing this at 6 weeks. If you feel safe and comfortable doing it earlier than that, you certainly can. These are very gentle exercises that are meant to, like I said, strengthen from the inside out. So the first one is your diaphragmatic breathing with the TRA and the pelvic floor contraction. So she's doing this on the ground with the hand on the belly and over the chest so that you can really monitor your breathing to make sure that you're doing that with good coordination, making sure that on your exhalation, you're drawing the belly in, drawing the pelvic floor in. This is one of the best exercises to start with because not only are you really trying to coordinate your breath, but you're activating those muscles that have been disturbed during your labor and delivery, whether you had a C-section or a vaginal delivery. The next 2 are a progression from the first one. So it's the same idea, the same contraction of the 2 muscle groups, the PFM and the TRA, but now you're doing a clamshell or bending the knee to fall out to the side and back in. So now you're creating a little bit more stress on the muscles. So if you feel comfortable doing the first one, you can move on to the first and second ones. The second one is the same idea, except you're doing a march position. So you can see, I mean, I'm not doing an entire progression of postpartum exercise, but these three are a really good place to start, just to kind of see how your body feels. Does my core feel really weak? If these are difficult for you, you should stick with them until they feel too easy. That's my general guideline, is if there's any pain or difficulty, you should not move on to a more dynamic exercise until you really feel comfortable with these. Because if these are difficult, that means you have a pretty significant amount of core weakness, and you wouldn't want to try anything that's harder, because that can actually make a diastasis worse. But these are safe to do. Other things that you'd want to think about, supportive bracing. So you can bring it to the hospital, just as typical, just abdominal brace that goes around the belly to cinch things together. If you feel like you had a diastasis in pregnancy, you'd want a brace postpartum. You can wear it right after labor and delivery, just to feel more comfortable in the hospital when you're lifting the baby. And then certainly when you get home, if you feel like the diastasis is prevalent, you want to wear that during any lifting activities. An activity modification, you don't want to do any kind of sitting up. You always want to log roll in bed, and just try to activate that muscle when you're moving so that the diastasis doesn't separate more. Okay. I don't mean to be moving too fast. I just want to get through everything. Okay. Prolapse. This is something that I see very often in the clinic, and it's often one of the most upsetting things that women come in with. If they feel like they see something falling out of their vagina, it's very disturbing, and rightfully so. I have a lot of women who come in and say that their gynecologist said nothing's wrong, but they know something's wrong. And I'm not sure why the gynecologist or midwife doesn't diagnose it, but I think it's because prolapse is so prevalent postpartum. About 90% of women experience prolapse. They might not be symptomatic, but it happened. It's so prevalent, but it typically resolves. So I think the doctors just don't want to like diagnose or scare patients, but it is disturbing if you feel like you have a bulge, or if you feel like something's different and there's something you can do about it. So we'll go over the different types. So uterine prolapse is a prolapse of the uterus. A cystocele is a prolapse of the bladder. And I just want to make it clear that the bladder is not, I can't even see which one, this one. The bladder is not actually falling out. The bladder is pushing into the front wall of the vaginal opening. So what you're seeing, if you see a bulge, it's actually the vaginal wall, not the actual bladder falling out. Same thing with a rectocele or the rectum prolapsing. The rectum pushes into the posterior wall of the vaginal opening. So that's the bulge that you're seeing. So there are different grades of a prolapse: grade 1, 2, 3, and 4. Grades 1 and 2 are mild, and they're usually well managed with physical therapy, activity modification. Grades 3 and 4 are a little bit more severe, and they may require some kind of medical intervention. It's most typical to have a grade 1 or 2 after labor and delivery.
Laura, can I ask one quick thing?
Yes.
Sorry. When you say you can see a bulge, what do you mean see a bulge?
So like if you were peeing or something, and you had a mirror and you looked, you might see something at the vaginal opening that wasn't there before. Like you might see like a pink sort of tissue there.
Gotcha.
Or if you just had a bowel movement and then you were to look, you might see something has been pushed down.
Got it. But you would feel something was off.
Yeah, you would feel, so symptoms might include, like you'd feel a bulge, like a tampon falling out. You might have painful intercourse. You might have a weak urinary stream if you have a cystocele or bladder prolapse. And if you have a rectocele, you could have trouble emptying your bowels, because the rectum is pouched forward. So stool can get caught right here, and you wouldn't be emptying fully.
Got it. Thank you.
Yeah, no problem. So again, I'm scratching the surface of all of this. Like if you feel like you have a significant prolapse, you definitely want to be evaluated. But if you feel like just something's a little bit off, or you see a bulge that wasn't there before, there are things that you can do that certainly will not create any, create any issues.
Would you feel it?
Excuse me?
Like, would you be able to, I'm sorry, can you hear me? Because I'm on my
I
head.
can hear you.
Yeah.
Mhm.
Would you be able to feel it?
You could feel it.
Yeah.
Yes, you could. Where was I right here? So when I often have people, like when you're wiping, you might feel something that wasn't there before. Or if you just took your hand and placed it right at the entrance of the vaginal opening, you might be able to feel it then. Okay. So risk reduction and treatment. So if you feel like you have this, you can do something called supportive bridge pose. So gravity is going to worsen the prolapse. So I evaluate this with people lying down, and I have them bear down as if they were having a bowel movement. And I actually look to see, like, if something's descending, how far it's descending, and I can grade it based on how far it descends. So if it's actually coming out of the vaginal opening, that would be like a 3 or 4. So that's a little bit more, severe. But if I just see the wall descending down, that's more like a grade 1 or 2. So that's something that's very treatable with therapy. So if you're somebody who stands on their feet all day, or if you're somebody who has to carry a lot of things, you want to try to engage your pelvic floor muscles while you're doing those activities. But more importantly, if you're going to do pelvic floor strengthening, you want to do it in a gravity eliminated position. So I often tell patients to put 2 pillows underneath the hips. You could use a yoga block or a bolster. You could put your feet up on a TheraBall just to get your hips kind of elevated. She's not quite elevated enough. You could even like throw your legs over the couch just to get those hips a little bit higher than the shoulders, putting you in this gravity eliminated position, so that when you do your pelvic floor exercises, everything is slid back a little bit. You can imagine if you're standing trying to do your exercises and you have a prolapse and you're squeezing, that could actually worsen the prolapse. So you want to make sure that you're in that gravity eliminated position to do the majority of your exercises. That's the most important thing with any grade of a prolapse. You want to do your exercises in a gravity eliminated position to start. So I usually start clients with this, and then I recheck them in 2 or 3 weeks to see if things have gotten better, and then they can progress to doing their exercises in a sitting or standing position. So it's the general guidelines are, your PFM and TRA activation in the supportive bridge pose. I think I forgot to mention too earlier, when you contract the lower abdominal muscle, that actually pulls the pelvic floor muscle in as well. Like if I'm doing an internal exam and I ask the patient to activate their transverse abdominis, I feel the pelvic floor activating as well, because the muscle fibers are connected. So when you're contracting your lower abdominal muscle, that's helping your pelvic floor to strengthen as well. Some other non-invasive interventions for prolapse include a pessary. So pessaries are usually for like a grade 3 or a more severe grade 2. It's actually a device that's fitted by your healthcare provider, a gynecologist or midwife. It's actually it's inserted into the vaginal opening, and it supports the prolapse. So again, that's something that if you felt like you had a more severe prolapse, that's something that you could look into. Sometimes I recommend it for clients who don't make progress. The Poise Impressa is something that's bought over the counter. It's like a tampon, but it's for support of the pessary, for support of the prolapse. And then there's compression wear. There's underwear that have compression right in the vaginal area. So if you feel like you have something bulging out, this kind of supports it if you're somebody who does a lot of lifting. So not something I often recommend. Okay. Everybody good? All right.
I have a quick question. Is the pessary similar to like a yoni egg? Or is that completely different?
I'm not familiar with that. Is that something for exercise purposes, or is it?
Yeah, so it's like a stone usually, like a smooth stone. I have one that's like rose quartz, but I've had it for years that I'm like, I don't know how to use it. It scares me. I don't know.
Yeah.
But it's just something that you insert. And I think just by it being, inside, your muscles are
Activated.
Yeah.
Yeah.
Exactly.
So that is more for like similar to like pelvic weights or like for exercise purposes, whereas this is really just to provide support to the prolapse.
Okay.
But I often don't recommend it for people who don't have a severe prolapse because it's really doing what your muscles should be doing. So the pessary is kind of for somebody who maybe like doesn't feel their muscle contraction, has like severely weak pelvic floor muscles, who I don't think would really get strong enough to support their own prolapse. So that's when I would recommend a pessary. And they're all different kinds, and it's a whole other world.
You look that up.
Yeah,
Thank you.
you're welcome. And then, okay. I actually skipped one thing. I'm gonna skip it for now, and if we have time, we'll go back to it. It's pubic symphysis pain. I'm going to talk about other pelvic pain first, and I'll go back to it. Actually, no, I'll just go back to it right now. So pubic symphysis dysfunction. Whoops. So the joint between the two pelvic bones, this cartilage right here, that's called the pubic symphysis. So when as the baby grows, and if the head is down and engaged, that puts a lot of pressure over the pubic symphysis. So as that pressure increases, and then the hormone relaxin causes the laxity, there's a lot of movement that occurs in that joint. So you could have an actual separation or an upslip or a downslip of the pubic bones, which causes a lot of sharp pain right over the pubic area. You would know if you had this because it is very uncomfortable and it makes it difficult to walk, and you have a very sharp pain over the pubic bone. So I often have pregnant clients come in with this issue. It's pretty painful. And I always say, like, you know, after labor and delivery, it typically does resolve to an extent. Especially like after the first few days, it does resolve, but things that you can do if you do have this during your pregnancy. So stabilizing the core with these 3 exercises, squeezing a ball between the knees to try and activate the pelvic floor muscles and the inner thighs can help to stabilize that joint. Doing a mini bridge with your pelvic floor and lower abdominal contraction. And then again, that exercise against the wall to try and lift the belly off the pubis. Those are the best exercises to try and do if you have this pain. Supportive bracing is a big one. I always recommend a sacroiliac or an SI belt. The one that I most like, and I'm not getting any money from these people for saying their names, but the Sorolla or the Stork support. The Sorolla belt is a thin belt that goes around the hips that really creates that nice compression that you need to stabilize the pubic joint. So that's really what I recommend for pregnancy, because sometimes the exercises and the activity modification just doesn't cut it. So you really need that support. You wouldn't want to do any kind of lunging or unilateral stance or anything like that. That's going to create more pain in the pubic joint. Okay, so we're going to move on to pelvic pain. So pelvic pain can occur for a number of different reasons. And this is, I'm referring mostly to postpartum here. So tearing from, so natural tearing can occur during a vaginal delivery, or even, you know, if you intended on a vaginal delivery and then had a C-section, you could still have some natural tearing, or an episiotomy is when the perineum is actually cut because of the baby like wasn't fitting otherwise. So either one of these tears can cause pain in the postpartum period. Pelvic floor tension. I'm sorry, I'm going to go back to tearing for just a minute. So typically the pain resolves when the stitches come out. But as in any other type of healing, when you have an incision, there's layers of healing. There's the fascial layer heals, the skin layer heals, the muscle layer heals. So that can cause a lot of tension in the muscle and the skin. So that can cause pain and discomfort. So doing some kind of like massage afterwards to that area can be really helpful. And again, it's hard for me to tell you how to do that on Zoom, but that's something, if you do have pain from tearing, that's something that you'd want to get evaluated if it lasts long after the stitching comes out. Pelvic floor tension arises because when you have when you push during labor and delivery, your muscles are expanding more than they ever have. So I always, this is terrible, but I kind of relate it to a whiplash injury. So when you have whiplash, your neck muscles are stretched beyond their comfort level, and then they come back and they get super tense and painful. So your pelvic floor muscles are forced open and then they recoil. When they recoil, a lot of times they return to their normal resting tension, no problem. Other times they can recoil and then get very tense to the point where you have muscle aching. Just like any other muscle in the body, those muscles are the same and they can be painful. So that can certainly occur after labor and delivery. Abdominal pain from a C-section incision is something that I see quite often. Again, that incision heals in multiple layers, so it can become very tight. So, and we'll talk about some ways to treat that. And then pain with intercourse, we'll talk about that on the last slide. So with episiotomy and tearing, in order to reduce the risk of this, at 34 to 36 weeks pregnant, you can start perineal massage. So I'll use my model here as best I can, but you or your partner, if you have one, can take some lubrication and just gently use a thumb or a forefinger to rub the perineal tissue along the vaginal opening. So it helps to really try to stretch that tissue. It's not necessarily going to stop it from happening, but it reduces the risk of it. And then some gentle pelvic floor stretching can be helpful as well. And we'll talk about that in just a minute. So pelvic floor tension can be really helped to resolve with relaxation training, diaphragmatic breathing, pelvic floor stretching. So these 5 are ones that I typically give for anybody who has pelvic floor tension. And by that, I mean there's pain to the touch of the pelvic floor muscles. So the first one is that diaphragmatic breathing. So like I said, with the inhalation, the pelvic floor muscles are going to relax. So practicing that breathing. When you exhale, you don't want to contract. You want to come back to a neutral position for this purpose. The happy baby stretch, a yoga pose, is actually a stretch for the pelvic floor muscles. So you can do a different, if you need to modify this by not bringing your knees all the way in, you could do it one-legged. That really helps to open up those pelvic floor muscles. Piriformis or outer hip stretch is very helpful because that's part of also the pelvic floor muscle system. Stretching the inner thighs is really helpful because those muscles are attached to the pubic bone here. So if you stretch open the adductor or inner thigh muscles, that can help to relax those pelvic floor muscles. And then the hip flexor stretch. This is a really nice, gentle way of stretching the front of the hip. So these 5 can be really helpful if you feel like you're somebody who falls into the category of pelvic floor tension. And then lastly, a C-section incision. I really encourage anybody who opts for a C-section or has a C-section, because of something happening during your vaginal delivery. It's really important to acknowledge the incision, touch the incision. Typically at 8 weeks postpartum, we start to really do scar tissue massage and desensitization. I have a lot of clients who ignore their scar because it's something that maybe they didn't want a C-section or it's painful, but that can just lead to more pain down the road. So this is something that's really important to focus on if you do have a C-section. Really touching it, rubbing a towel over it, anything to desensitize the tissue, and then starting scar tissue massage. And I would recommend under the supervision of a pelvic floor therapist or somebody who's familiar with that. Okay, back to intimacy in the postpartum. This is the last slide, and I just wanted to do it a little bit separately because I think this is one of the hardest things that we as women deal with. Intimacy is such an important part of our partner relationships. I think it's something that we judge ourselves for if we're not up for it. And I think it's just something really difficult that we all deal with. And you go to your gynecologist or midwife at 6 weeks and they give you clearance to have intercourse. Great. Not great, because you're not always ready for it. And I think it gives you a false sense of there's something wrong with me if I'm not ready. So I think this is so important that if you feel comfortable, to talk to your partner about not being ready, taking it slow. If you have pelvic floor tension, that can make intercourse really painful and difficult. So doing stretches with your partner. If you are going to attempt intercourse, really taking it slow, doing a lot of foreplay, making sure that you're lubricated, whether it's naturally or with a lubrication, just to make sure you're really ready, because it can be traumatizing if you try to have intercourse and it's painful, and it can make you not want to try it again. So the other thing that I often recommend for patients are dilators. This is something that you'd really need to see a practitioner to, learn how to use them. But these are progressive vaginal dilators that actually stretch the vaginal muscles if you have a severe case of pelvic floor tension. And I've seen these work really well for clients who just had so much tension they weren't able to accept any kind of penetration. This is really helpful. So again, back to intimacy is such a personal thing. Everybody is going to experience it differently, but I encourage you not to feel bad if you're not ready at 6 weeks, because it's not common that you're going to be ready at that time. Okay. Sorry. I feel like I rushed a little bit at the end because we're kind of over time, but ask me anything. You can ask me in the chat, or you can just unmute yourself. Or not.
I guess I'm not even just maybe asking, but I feel like it was affirming to me, because and this is going to, obviously this is a conversation we're having, so I guess it's like kind of gross, but it is what it is, that I'm like, why do I feel like I sometimes have to push my poop out of my body? Like, what is up with that? Right? It's like such a weird sensation and feeling. Yeah. And now I'm realizing, like, oh, right, because it sounds like there's a little bit of something going on. So,
yeah,
and I think that in my head, I was kind of like, maybe I'm just crazy and I never realized before that I could have done this, like I thought it was like, maybe I just got like more intimate with myself and understood my body, but but then I'm like, oh no, I don't think that's normal. So
yeah, I mean, there could be some sort of prolapse. I mean, I sometimes teach splinting, like actually physically, going in with a thumb and pushing. If you have that pouch in the front, you can actually push. There's devices for it. Or there's, if strengthening is something that strengthening can also help that to kind of push the wall back where it should be, which could then help you to evacuate without having to push so much, or physically push, or like with your digits.
Yeah. It's a weird sensation. So yeah. Anyway, with the queen of overshare.
I appreciate you sharing. No, there's no oversharing.
You know how I roll, so.
Well, I'm sitting here wondering if I ever had a prolapse too, because I remember like feeling like soon after delivering, I had a vaginal delivery, and I was like afraid of taking a mirror and looking at myself. But I remember I would sit out, I have these big windows in the sunroom, and I would like just sit open-legged, get sun to like heal. I had a level 2 or 2nd degree tear. Mm-hmm. And it took a long time to feel comfortable and to feel, like it wasn't painful. It took a long time for me. And so what you said about, being cleared for intimacy, that was like the worst thing that the midwife could have said in front of my husband. Cause I was like, no.
Back up.
Yeah. Who are you? But yeah, I remember feeling there was a lot of pressure, and I'm curious. So you said like prolapse oftentimes can just sort of resolve itself over time.
It can resolve itself as your hormone levels kind of go back to normal, and that laxity kind of leaves the body. The ligamentous laxity improves, so that can help everything to kind of go back to where it was. So that's why I said often, I have actually spoken to a couple of gynecologists and midwives that they don't give that diagnosis because it is a prolapse, but it's something that they have seen resolve, so they're not concerned about it when they see it so soon postpartum. But if I have a client who comes to me and they're very concerned about it, there's nothing wrong with trying to improve your situation, even if it might resolve on its own. There's nothing wrong with getting into those anti-gravity positions, just knowing the things that you can do to make sure it doesn't get worse. I think that's the education that we provide, or we try to provide to our postpartum population. So, yeah.
It is one of the most under-supported populations, like, and it's wild. So
Yeah.
it's wild. And I say that in full knowledge of, like, I know there's many people in the world that are underserved, and anyone who knows me here knows that so I'm like, I don't want to sound like this super privileged, like, postpartum, but it is amazing how little attention and conversation is paid or given to it. So.
Right. I'm just happy, like Danielle said, she's studying to be a midwife. So I hope in your practice that you send all your patients to pelvic floor rehab. Or teach them things, because now you know a lot of things. So
Right. I was going to ask you, can you go over the nap technique one more time?
the knack, sure.
Yeah.
So the knack technique is basically doing a Kegel contraction, doing a pelvic floor contraction, but doing it purposefully if you cough or sneeze or before you lift something. So if you're somebody who has stress incontinence, like if you were to do a squat and leak, or if you were to lift something heavy and leak, cough and leak, you'd want to, it's hard. Like if you feel a sneeze coming on, if you feel that tickle in your nose, try to contract your pelvic floor and hold it as you sneeze. Easier said than done, but with practice, I've seen that be helpful just for that, like, okay, I won't like squirt out some urine when I cough or sneeze. If you try to really purposefully contract those pelvic floor muscles.
Awesome. Okay, great. That'll be a good one to keep in my memory in case someone says they have a problem. I can teach them that.
Exactly, because I feel like so many things that not everything is a quick fix, obviously, but little tips like that can be super helpful. Yeah, without having to go through a whole therapy thing or so.
Yeah. So you mentioned, like, obviously I've done clinical now for a couple of semesters, and my preceptors have been awesome about referring people to pelvic floor PT, but I know it's really high demand right now and not so many providers. So there's really long wait lists. So, like, what advice do you have as far as how do we know when should we just always refer, or is there cases where we should just like say, oh, maybe we should wait it out a couple more weeks and then let us know if you want a referral kind of thing?
Yeah, I mean, I think, if somebody is expressing that they want to be referred, I would do that. But I would also, I mentioned this to Carrie, I wanted to, there's a website called pelvicrehab.com, and that you can search by area code, and it shows all the pelvic rehab practitioners in that area. So it's pelvicrehab.com. And so I know, for example, I mean, Danielle, firsthand that where I work, we have a super long wait list. So we try to get in pregnant and postpartum women, like they're like considered priority patients. So we do try to get them in sooner. But if you can't get in somewhere, like I would go on pelvicrehab.com and see if there's any other practitioners in the area. Because there are, like, they do exist in this area beyond, the obvious ones. I can't say it because I can't say where I work right now, but I think it's important to get in if you need it. But if you feel like, for example, if somebody has a prolapse and you're seeing them at 4 weeks postpartum, you can kind of assure them that, it's something that's very common and that does resolve. But if they feel like in another 2 weeks, they're still having symptoms, maybe then that they could see a practitioner. I would always I would affirm that what they're feeling is real, but that quite often it does resolve. Not to say that yours definitely will, but just to kind of give them some sort of, comfort,
Reassurance.
Yeah.
So if I see someone for their 6-week postpartum visit and they're saying that they're already having issues, I should just refer them.
I would.
That's kind of the point where they should be kind of like healed at that.
Yeah. Yeah.
date.
Then you can
Okay.
call me and tell me who they are and tell them I have to get them in sooner than later.
Okay. And then you'll do your best, but it's so hard right now. Yeah.
But there are, I mean, when I went to pelvicrehab.com, there's a lot of practitioners in Rhode Island and some others like in the South Coast area. So I'm talking about our
Yeah.
area. Yeah. So, but it's difficult. We
Yeah.
need more.
But this was awesome review. Thank you so much. I really appreciate it.
You're welcome. And good luck with the rest of your program. It's exciting.
Thank you. I graduate in May.
Wow, that's awesome.
Yep.
And you had another baby, right?
Yep. Because why not?
Why not?
Yep. So now I've got 2 boys.
Oh, that's awesome.
Mhm.
Very good. All right.
All right, I have one more question.
Yeah.
So your pelvic floor muscles, we talk about them being weak and strong, sometimes having tension. Does your own individual baseline just like depend on your exercise, your individual anatomy? Like, are there certain things, when you become pregnant, you don't necessarily know your pelvic floor and sort of like your baseline yet, I guess. So I don't know, I'm like skirting around asking a question about myself. I'm trying to make it more general to get everybody to see if they can relate as well. But I felt like my pelvic floor was so tight. I had such a long labor. I felt like it just wouldn't let go. And I'm so familiar with the releasing and the letting go of the muscles. Like I have a deep feeling and I can sense these muscles, but they just wouldn't let go. There's also an issue with my bladder being really full. So just like a lot of pressure. So yeah, back to the original question, like, what is someone's baseline pelvic floor based off of?
So if I'm evaluating a patient, I do an internal exam and it's very, it's my finger, like feeling the muscle, and I have a sense of, is this muscle very tight, or is there a lot of like room? Is the contraction strong? What does the relaxation feel like? And do you have pain to the touch? Some people who have tension don't necessarily have pain to the touch, but if I'm saying somebody has increased pelvic floor tension, it's because when I feel the muscle, it feels more like a flexed muscle than a soft muscle. Does that make sense?
Yes.
And and I also base it on your contraction. So just because you're tense doesn't mean that you're strong, right? And I'm not saying you, I'm just saying in general. So I could feel somebody's contraction that's already tense. They might have a really weak contraction and a weak let go. So you might have like not a lot of movement there. So I would say that that's a weak and tense pelvic floor, versus somebody who has a lot of like laxity of the muscle and sort of, I'm going to use the word like just a little bit more squishy. But when they contract, I feel a big contraction and then they really let go back to their resting baseline. That's a more of a normal resting tone. Or somebody who has like no muscle tension at all, and their muscle is like very soft. They might have decreased muscle tone. So I'm basing it off of a manual exam. We also use something called EMG, which is where you put a sensor into the vaginal opening and it reads your muscle tension on a screen. And we have like baselines of what would be elevated and what would be normal. So we could use that as well, which is a more like, what's the word? Like, if me and somebody else evaluate you, like we could both have differing opinions on whether your muscles are tight or not. But if we use the biofeedback or the EMG, it's going to tell us the same thing.
More objective.
More objective. Yes.
Yeah.
Yes, exactly. Yeah. So, that it's tough because when I have a pregnant client come in, I also don't know what their baseline was prior. So if I have and a lot of times my pregnant patients have a lot of pelvic floor tension. So I can't teach them strengthening. If they have incontinence, it's probably due to something else. It's not necessarily just a weak pelvic floor. It might be an urge issue. It might be behavioral. It might just be that the baby's sitting on the bladder. There's a lot of nuances that you have to take into consideration. So that's why it's, with this Zoom format, I'm doing very generalized exercises, but they're not going to be appropriate for everybody. So if you do have any concerns, especially with pelvic floor tension and pain, that's when you should get evaluated, because there might be a more specialized treatment plan. I don't know if that answers your question, but
Yeah, absolutely. Perfect.
yeah.
Does anyone else have any questions before we close up?
I think one thing just to and this is just a comment, is I think it's interesting how as women, we don't know our pelvic floor before pregnancy and birth. And so then we don't really know what's normal or not normal after pregnancy or birth, which is why I could sit here, I'm 18 months postpartum, 19 months, and I'm like, oh, that's weird that I have to sometimes I push, So
Yeah.
I think that has a lot to do with it, is we just don't know, which is kind of off of your point, Carrie, which is what made me think about it. So
It's important awareness.
It is. It really is. Thank you so much, Laura. This was so great. Like I said, I have a self-assessment video that I'm happy to share with you all. In the Motherhood Yoga Village video library, I also have a series. You were moving through a lot of great exercises, and I was like, we do that too.
Awesome.
So we have core level 1, 2, and 3. And they move through a lot of similar exercises that Laura was showing us tonight in terms of diastasis recti. We were talking about the pronunciation, so you might also hear it as diastasis, but we both agree that we like to say diastasis instead. So I have those videos in the library, and any other, there's so many parallels to physical therapy and yoga, and that's just a fun, exciting thing to know that we can learn things in so many different settings that are going to support our bodies during this time.
Yeah. And I always tell clients yoga is a really great place to start postpartum, at different levels, just because it is all about the breath and activating the core. So it's a great way to kind of reintroduce exercise in the postpartum period.
Absolutely.
Yeah.
All right. Well, I will be getting all of this information to you, the slides, the recording, the video, like I said, and then also that link for the pelvicrehab.com. So we have some more resources. Thank you again, Laura. Have a great night, everybody.
Thanks, everybody. Sorry it went
you.
so long, but
Thank you.
Thank
So
you. This is
good.
great.
Thank you.
all right. Thank you, guys. Bye.
Bye, everybody.
Bye.